Okay, we will actually move on to our next speaker. That will be Dr. John Prowell, and he will speak to us about trajectories of critical illness, defining endotypes from routine data.
Well, I wasn't expecting that, so and I was going to start off by saying it's a great challenge to follow Derek, who actually I see is at the back there. So, but you happy for me to carry on? Yeah, okay. But it's an even greater challenge to replace him in the program, but I think we'll get his talk later. But that's so, and this is also a slightly speculative talk. So I hope you'll indulge me a little bit with some of my musings. I have a few declarations that are relevant to this talk. And so I really want to talk a little bit about modelling to improve care of the critically ill. And there's a lot of challenges we have here. There's sort of the dichotomy between trying to predict outcomes and actually trying to understand patient characteristics. There's our ability to kind of supervise our learning and impose our own thoughts about what critical illness is versus using unsupervised learning to find new things. And then there's also this idea of whether we're actually finding true groupings or perhaps we're just looking at continuums of risk and identifying patients at either end of those. And most importantly in this talk, I want to talk a little bit about baseline characteristics versus change over time. So here's the dangerous bit. I'm going to talk very briefly about the different sepsis phenotypes, but really to remark this is a huge achievement, but these are based on very, very early assessment of the patient. And fundamentally as well, these phenotypic clustering is very powerful, but it's particularly powerful because it's derived on routinely measured data we have before us every day, can be generalized to many different populations to explore these different patterns of early sepsis and critical illness. And obviously we're very familiar with these different phenotypes, but maybe as we're kidney people, I'd like to reflect that groups B and the delta and the beta groups are both associated with renal failure, but it's probably renal failure of a quite different flavor in the group with the fulminant presentations versus the group with the likelihood of chronic kidney disease, likelihood of other chronic diseases, perhaps a little bit less severe overall, but presenting earlier with kidney dysfunction. And the other thing to point out is that these phenotypes based on routine data don't necessarily segregate so well with phenotypes based on other forms of endotyping, with gene expression and other molecular markers. And this doesn't reflect a sort of failure in the process, it reflects that things are very complex. But the most important thing to say is this is all based on very early measurements of the patient's characteristics. And what we have then is patients with similar characteristics, but they can pass through many sliding doors, as it were, in their pathway through critical illness and arrive at very different outcomes. And that's an inevitable feature of the phenotyping. And so we shouldn't say that phenotyping is wrong because it occasionally gives us the wrong outcome prediction, but B, it's also very important to understand the patient's trajectory after their initial presentation to really understand what's going to happen to them. And our patients in the ICU, we can have rapid recovery, we can have early death, but actually it's these patients who get stuck in orbit with prolonged ICU stay that perhaps is most fruitful in terms of manipulating their outcomes, and we may be able to nudge them into escape velocity, and what we don't want them to do is fall down back to earth and death. And we have a number of constructs we've used to describe this process, including this persistent inflammation, immunosuppression, and catabolism, PIC syndrome, reflecting chronic catabolism, immunosuppression, and inflammation. But it's important to remember that this is a construct we've created, and while it may have a huge amount of insight in there, there's also the possibility of a prosecutor's fallacy, that if we go looking for these characteristics, we will find them in populations. And so there are other approaches which are based on untrained looking examination of the data, and Jackie Washner championed one of these. And this is really defining persistent critical illness based on the timing of critical illness, where the a patient's antecedent characteristics is more important than their baseline illness in terms of determining their outcome. And really what I say of this phenomenon is that what we have here is a patient in the critically ill, in the ICU has been critically ill for many days. And the question is, if we can peer through all the machines, what is actually wrong with them to bring them into ICU. And the fact is that we have no idea unless we go and look at the chart. They're much more characterized now by their present organ dysfunction than the initial presentation. They have gone through many sliding doors to arrive where they are. But there are many issues with chronic critical illness or persistent critical illness. There are concepts. There's little evidence to say how patients transition between the states, and we don't really know about biological signatures. Now, my particular feeling about critical illness, and this is personal definition, is that really it's defined as organ failure needing advanced monitoring and support. But it's very important to point out that many of the organ failures may be acquired during illness, and some of them may be relatively covert, like sarcopenia, but extremely important at driving outcomes. And various people have then tried to look at trajectories of critical illness, and this is just one example where they use this latent class mixed modeling to determine clusters of SOFA score during critical illness. This is from the Philips EICU database, and they developed these different clusters within the patient population here. And it's interesting to reflect they had different outcomes, and actually the cluster with a rising SOFA score late in the ICU had worse mortality, worse than patients who actually came in with a high SOFA score. Provocative, needs some further validation, but there is a question here. Are we kind of reinventing the wheel? Is this a non-circular argument, as it were? We're talking about a measure of organ failure and its persistence. Am I really just saying something incredibly trivial? So we've done some work to try and look at characteristics of persistent critical illness, and I'll go through a few bits of this, but obviously we're looking at various candidates, and we did a study looking at a large number of trauma patients. I work in a large trauma ICU, and they have a relative degree of homogeneity at outset to perhaps allow us to get a few more insights into their trajectories. And we looked at patients who were in ICU at day 10 and those who'd been discharged and alive. So we're counting out here the early fulminant presentations and death. And these are the trajectories of various routinely measured parameters in the blood in our patients over time. And what you can see here is the marked decrease in creatinine, which we think reflects sarcopenia, a rise in urea, which we think reflects protein catabolism, and a marked rise in urea-creatinine ratio here. And these different trajectories are distinguished by the length of ICU stay. And so longer ICU stay at the top in the urea-creatinine ratio, which is at the top right-hand window. And then we looked at other parameters like albumin and hemoglobin, which do seem to segregate with these different durations of ICU stay, whereas some inflammatory markers, such as CRP, neutrophils, lymphocytes, NLR, have interesting patterns, but less characterize the trajectory of our patients. You can also look at AKI, and obviously it's very interesting to look at trajectories of creatinine and urea in AKI, which are quite out of sync with each other, reflecting undergoing metabolic changes in our patient. Actually, the UCR pretty relatively invariant to the AKI stage, suggesting it has some validity as a marker of hypermetabolism in these patients. We also looked at the ability of UCR and hemoglobin in combination to predict the patient's ICU status versus a model which included their antecedent characteristics and their illness severity admission to ICU, which is in blue. And what you can see over time, what determines whether or not in your ICU is your current kind of metabolic profile as opposed to your baseline characteristics or what brought you into ICU, kind of, again, telling us that when we're getting through the ICU stay, we need to understand where the patient is on their trajectory and not just what brought them into ICU in the first place. And I'm going to finish up with some results we had from COVID. This is one of our purpose-built COVID ICUs that we had. We had lots of them, and we filled them all with a peak of about 150 patients. And this enabled us to do a lot of work for patients who were both critically ill and acutely admitted to hospital with COVID-19. And again, we've got a relatively homogeneous exposure, and it's interesting then to reflect on the trajectories. A lot of this work was based around ethnicity, because we have a very ethnically diverse population in East London. But I'm not going to dwell too much on that in this presentation and talk a little bit more about trajectories. And what we did was we took our routinely measured data and we used k-means longitudinal clustering to try and understand different patterns in this data. And this is highly exploratory, this phase. This is a powerful technique. It's probably better at looking at single variables, but you can do multi-dimensional clustering, and we may do that in the future. You need a lot of data. There are issues like determining the optimal number of clusters, and there are a number of techniques for doing that, but that is really an unsolved problem, and it needs a degree of expert insight to help us guide us in that process. It's non-deterministic, so you need to ensure that the clusters are stable and reproducible in other populations. Importantly, it is quite powerful in its methods of imputing missing data, and so it can deal with intermittent missing values by imputing them through the trajectory, and it can also use monotone missing values at the beginning or the end of a set of values, and it uses the overall profile in the distribution to tell us the direction you go from the last value. And so we did this in our data set, and this is, as I said, up to 3,000 patients. But we looked at a subset who had been in hospital, were in hospital for 7 days or more in order to get a valid trajectories in these patients. And then we looked at the trajectory of their routinely measured tests over a 15-day period and saw how that segregated with their overall outcomes. And you can see some interesting observations here. So for instance, in COVID-19, having a lower platelet count after COVID-19 exposure is associated with increased mortality. And this has been shown by other investigators. If you get COVID-19, you make an appropriate immune response to it, you probably should get a degree of thrombocytopenia, and if you don't, something is wrong. Now, this segregates with age, but actually the effect appears to be independent of age in terms of its effect on mortality. White cell count, perhaps a little bit more trivial in terms of its association. And what we have here as well is we have the first and second wave, and the clustering was done independently in the two waves, and the associations are similar. This is providing some interesting and provocative insights. Here is CRP, and this shows some interesting differences between the two waves. The first wave here on your left shows, I apologize, the first wave here is on your right, and this shows an earlier rise in CRP, which we didn't see in the second wave, and where, in fact, there was a group with a late rise in CRP. And this could be attributed to the increased use of steroids, but again, the high CRP group had the worst outcome. Again, we looked at UCR as a signature of perhaps persistent major illness, and there was a segregation in terms of mortality there, again, potentially validating this as a signature, but again, the direction of causality is interesting. We could obviously look at characteristics between these clusters, but for the purpose of time, I'll move on. We're able to do clustering for several other variables. I'm afraid some of the spaghetti plot is lost here, but there are some interesting observations. Again, albumin is segregating very well with outcomes. Hemoglobin slightly less so. Being hypernatremic is extremely bad for you. Again, is this a reflection of what happens to people close to death, or is it something that we potentially intervene on? Difficult to say, but it does perhaps suggest that we should go and see patients who become hypernatremic and determine whether or not we can do something for them, not just based on their sodium, but their global physiological state. And again, these observations were quite consistent between the two different waves with independent clustering techniques. And we're able then to kind of explore whether the patients who died in different ethnicities were more or less representative of clusters and determine whether there are differences. I won't dwell on this. I think it is all driven by baseline healthcare inequalities between these groups rather than any biological effect. And we were obviously able to explore whether or not these cluster membership was independently or not associated with outcome by adjusting for some baseline variables. And it appeared, as you expect, because this reflects ongoing progression of the patient, but this was survival from 7 to 30 days. So the cluster membership was kind of established at that point. So these are, we examined the findings, and they were consistent across our two populations. So to conclude here, and this is highly exploratory and kind of hypothesis-generating work in terms of approaches to understanding trajectories, I think trajectories of routinely measured parameters do consistently segregate with clinical trajectories across the duration of critical illness. And this is probably identifying biological signatures of clinical phenotypes, and this could provide insights into underlying pathophysiology and treatment. But it's very important that we don't know the direction of causality here. Some of these are pathways that are leading to death, for instance, that may not be amenable to intervention, but they still identify patients at risk. And so the next step may be actually to see, rather than predicting the probability of an overall outcome like mortality that can have many different pathways that lead us there in our choose your own adventure book of critical care, that we can see if we can predict the patient's probability of being in a particular trajectory of a given analyte or analytes. That may give us some insight into what their underlying biology would be. And the interesting thing about these modeling with the clustering approach is that you can provide partial trajectories and get percentage chances of different membership of eventual clusters, and you could serially update that, and therefore there's a possibility to do some dynamic prediction. And this is where we would take this further. Thank you very much.